My name is Timothy Donahue. I am the Chief of Surgical Oncology and a Professor of Surgery at the David Geffen School of Medicine at UCLA and UCLA Health. The question is there a role for stereotactic body radiation therapy versus surgery, but with resectable pancreatic cancer? Not much data on this. We reserve stereotactic body for patients with resectable pancreatic cancers. We reserve stereotactic body radiation therapy as a local definitive therapy for those patients who are not surgical candidates or have too many comorbidities in order to undergo a surgical resection of their tumors. For the most part, these patients are usually started. So if there's a patient with too many comorbidities that cannot have a surgery, that has a resectable pancreatic cancer, ideally it's best to treat them with a course of chemotherapy or systemic therapy first, because this tumor has a very high predilection for metastases or metastases forming or developing. And then if after the chemotherapy they are deemed not eligible for surgical resection because of their performance status, then often stereotactic body radiation therapy is given as an alternate to surgery. But ideally, surgical resection is the best local therapy for these patients with resectable disease. And often like to tell patients that can't think of a case where there has been a patient who has been cured of pancreatic cancer who did not have their tumor surgically resected. Borderline resectable disease. Is there a role for stereotactic body radiation therapy for borderline resectable pancreatic cancer? This is a moving target. I think many places and centers do give or did give radiation therapy prior to surgery. And after a course of usually 3 months or so of chemotherapy for patients with borderline resectable pancreatic cancer before undergoing surgical resection. And that's because it's thought that it increases the probability that a margin negative resection could be performed, which has been shown to be obviously the most efficacious for patients. However, there was a recent alliance trial, the A021501 study that was presented at GI ASCO just this last winter that looked at radiation SBRT for patients with borderline resectable pancreatic cancer. There were 126 patients that were with borderline resectable pancreatic cancer that were randomized to either get 8 cycles of FOLFIRINOX chemotherapy or 7 cycles of FOLFIRINOX and then SBRT, and then be evaluated for potential surgical resection. The arm that got the 8 months of FOLFIRINOX had a better overall survival and better disease-free survival. And so I think that the role of radiation therapy for patients with borderline resectable pancreatic cancer is being increasingly questioned as a result of this recent prospective study that was done. What about those patients that have locally advanced pancreatic cancer? I would say that radiation therapy is used much more for these patients as a therapeutic modality than resectable or borderline resectable, especially with that alliance study that I just mentioned. And the patients with locally advanced pancreatic cancer undergo usually a total course of neoadjuvant therapy. So it's 4 to 6 months of induction chemotherapy and then radiation therapy after that. a consideration for surgical resection at that point. That's the guidelines that have been put forward by the NCCN just in the most recent version, of which I'm a member of that committee. And I think that they are also supported by some recent data, some good data that came out in JAMA Oncology, retrospective data from the Memorial Sloan Kettering group, where they showed that high dose radiation therapy, I think they gave 98 gray in a study with 119 patients, resulted in a median overall survival of 18.4 months and a 1-year survival of 74% in locally advanced pancreatic cancer patients from the time that they got that high dose radiation therapy. So all in all, I'd say that there's some mixed results for radiation therapy or SBRT in pancreatic cancer. The story is still not clear at all, a mix of prospective and retrospective data, but I would say in practice, people are not using it for, or at least as an upfront treatment for potentially resectable disease. Looks like probably less so for borderline resectable disease. But it does have a place in locally advanced pancreatic cancer. But that's with retrospective data, and perhaps there will be prospective data that will come out to support it going forward.